Invite Dr. Jarvis to come up and present a little word on Wiley Day and who Dr. Wiley was.
Okay, thanks, Kevin. Welcome, ladies and gentlemen, to combined surgery and pediatric rounds today. It just happens to coincide with our Division of Orthopedic 29th Wiley visiting professorship. And I can get this to... There we go. Because I think, many of you are not going to know Jim Wiley. I'm just going to take a minute here to bring you up to speed with who Jim Wiley was. And Jim was graduate of medicine at University of Ottawa in 1955. He went overseas and did a number of fellowships and then came back and practiced at the Ottawa General Hospital. And then in 1974, when this hospital opened, he and Bill McIntyre came over, and they were the first full-time pediatric orthopedists, certainly here in Ottawa, and to a certain extent across Canada. There weren't very many at that time. Jim was active in research and in education. He achieved the rank of professor of surgery, and he was assistant dean of postgraduate medicine here in Ottawa. He coordinated all the medical faculty alumni. He held a number of offices, and most notably was president of the Canadian Orthopedic Association. Jim had a lot of talents. He loved teaching. He loved to write. He loved to storytell. He was an orthopedic surgeon, so yes, he was a really avid carver as well. He wrote 3 books. He probably wrote many, but he wrote these 3 little books here that were just a series of anecdotes of basically his life and medicine, and a lot of them are about his work here at CHEO, and they're very, very entertaining. The last one he wrote was My Learning Tree in 2006 when he was in rehabilitation from his cardiac surgery. Jim was a consummate gentleman. His patients absolutely adored him. My first rotation in orthopedic surgery as a resident was here at CHEO, and he took me under his wing, and he was a mentor to me throughout my career and always supported me. In 1997, Merv Letts inaugurated the first Wiley visiting professorship in Jim's name. Sadly, we lost Jim in 2008. Ironically, it was actually the night before the visiting professorship that year. However, Jim, I know he would be really, really proud to see how our orthopedic group here has expanded to 7 stellar orthopedic surgeons, each with their own niche. He would love that. He would also be delighted with the array of visiting professors that we have attracted here, and this year, for sure, is going to be stellar with Dr. Wudbhav Sankar, and I'm just going to give Kevin a minute to introduce Woody.
Thanks, Jay. I'll get this set up for you too, Woody, try to make it a little easier. All right, it is a great honor to host Wiley Day today and to have Dr. Wudbhav Sankar as our visiting professor. It's not showing. Okay, we'll stop the share. We'll repeat it. Yeah. We'll share this one. Is that better? We always need a tech person in the room just to let us know, keep us on track. Again, it's a pleasure and honor to welcome Dr. Wudbhav Sankar here at CHEO in Ottawa. Dr. Sankar is really internationally renowned hip and spine surgeon. He's a mentor and really a world leader in a lot of the hip dysplasia stuff. I know that he's personally affected my practice with a lot of the research that he's done on it and his great presentations at international meetings. Dr. Sankar is coming to us from the University of Pennsylvania. He's working at CHOP, the Children's Hospital of Philadelphia. He did his engineering degree at Cornell Medical School in Pennsylvania, did a couple fellowships in pediatric orthopedic surgery in LA, and did a hip preservation fellowship at Boston. Boston's okay. We had Dr. Shore here a couple years ago. Dr. Sankar is way better. He is a member of many international study groups studying DDH, studying Perthes, and a lot of young and adolescent hip conditions. So hopefully today he will have the chance to enlighten us with a lot of his knowledge and experience. And this morning we've asked him to come and present to us and to the CHEO hospital in general and all the pediatricians on DDH and how it affects our children. So Woody, welcome to Ottawa. Hopefully it's not too cold, but it's not snowing like it was last week, so we're glad that you made it.
So thanks very much. It's really an absolute pleasure to be invited here. I was telling Kevin the story. When I was a resident, or maybe I was a medical student at CHOP on rotation, the first visiting professor that I remember, like the whole thing for somebody coming in for a day or two, was Baxter Willis. And so, and that's the first time I met him, got to know him a little bit, got to know him the years after through the society work and various international courses and things like that. And so when he reached out and invited me on behalf of your department, felt like it was coming full circle for me and was really exciting and really an incredible honor. It's really a pleasure to be here. These named professorships like this that have been around for 29 years are really something, and to be a part of that lineage is really humbling. So thank you for the opportunity. So I decided for this talk, because I realized that there's some pediatricians out there in the ethos kind of watching this lecture, to try to make this as least surgical as a surgeon can make a talk. And so I'm going to be talking mostly about the disease, the burden of the disease, a little bit about screening, and then the rest of the day we'll get into some more surgical things. So here we go. Not advancing here. It's on delay, I guess. Okay. All right. So disclosures, none of which are pertinent to this talk. So we think about DDH, really think about it as a spectrum of disease. Okay. It's confusing because the word dysplasia is obviously one of the three Ds or two Ds in that name, but we use it in multiple ways, meaning multiple things. So I think of it as this: on one end of the spectrum, you have just what we call stable dysplasia, where the femoral head is in the acetabulum, it's located, but the acetabulum is dysplastic. So there's less coverage coming over the center of that femoral head, and that can lead to some issues, as we'll talk about later. Then kind of in the middle of the spectrum, there's subluxation, where I think of the hip being decentered. And so that changes the mechanical forces inside the hip, which we'll also talk about. Now, radiographically, we define this as a break in Shenton's line. The inferior aspect of the superior pubic ramus and the inferior aspect of the femoral neck should be contiguous. This is a radiographic construct, as we were talking about yesterday, but generally those lines should line up in most patients. And if they don't, it implies that the center of the femoral head and the center of the acetabulum are not the same anymore. And there's some decentering going on. And then, of course, dislocation is complete loss of femoroacetabular articulation. Another way to think about this spectrum of severity is through this nice graphic that the International Hip Dysplasia Registry came up with a few years ago. And again, think of this like a continuum. This is how I explain it to patients. On one end, mild shallowness, and then you can have shallowness that becomes more severe. It's a more severe dysplasia. Then you get to a point where a hip is subluxable, and then eventually dislocatable, but able to be reduced. And then finally, the most severe form would be a dislocated hip that is irreducible. So when we talk about the burden of disease, it's all over the map in the literature, anywhere from less than 0.1 to 20%. But basically, if you call all the literature, the incidence is about 3 to 5%. Now, it depends a little bit on how you define dysplasia. And that's one of the things I think is going to be a recurring theme in this talk is there are lots of different forms of dysplasia. So where you draw the line depends on what you're calling dysplasia. Certainly if you include just dislocations, it's going to be less common. If you include patients who have moderate or severe shallowness but are located, your numbers are going to go up, obviously, okay? But this is kind of an overall kind of snapshot. There's a lot of ethnic variations. We know that certain ethnic groups have much higher prevalence of disease, particularly in Eastern European countries. Very low rates in Africans and African Americans. Native Americans, perhaps because of some postnatal immobilization, have historically had high rates of hip dysplasia. And then, as I mentioned, Eastern European descent, very high. I think this is helpful for the pediatricians out there in the audience, just to kind of put this in perspective compared to other archetypical pediatric diseases. So you think about type 1 diabetes, very common, classic pediatric condition. That's the incidence. ALL, that's the incidence. VSDs, celiac disease. You add all of this up, it's less than the rate of DDH, okay, just to put it in perspective. So it's pretty common. And so why is it a problem? So to answer this question, I'm going to break it down into those three categories again, and we'll kind of build the story from there. So dislocations are obviously a source of morbidity and disability. So especially if it's a unilateral dislocation, you're going to get a significant leg length difference. Patients generally do better than most people think. So unless you're a hip person, you may think that these patients are disabled at 2, 3, 4 years of age. Not true. These kids learn how to walk. They walk well. They'll walk with a limp. They'll walk with a leg length difference, but they typically will do well through their early school years. But eventually, when they start hitting double digits, they'll start to have some discomfort. Leg length discrepancies can reach up to 10 centimeters. They can have knee pain, valgus stresses on their knee. If it's bilateral dislocations, the leg length differences are mitigated. However, there's more stress on the low back, so these patients will walk with lumbar lordosis and have low back pain. Stu Weinstein wrote a nice study many years ago looking at the outcome of fully dislocated hips, like that x-ray that you see there. And what he showed, including some work that was done by John Wedge, showed that the outcome really depends on whether the dislocations are bilateral and whether there's a false acetabulum. So it makes sense if you have bilateral dislocations, the leg lengths are kind of evened out. It generally helps you if you're bilateral. And then if there's a false acetabulum that starts forming, those hips become more painful. So if it's up there in the abductors and the ilium, it doesn't create a pseudoacetabulum, those hips do better. That's the 52% acceptable results. If there is a false acetabulum, it becomes lower. And that's where degenerative arthritis becomes pretty common. There are certainly societal considerations. So there's this nice study from the 70s showing that Manitoba natives who had a very high prevalence of hip dysplasia, they actually did pretty well functionally through their teens. And the biggest issues when they carried canoes is that they would dip with their Trendelenburg gait when they tried to carry canoes. And that was their biggest complaint. I take care of a lot of patients that do come to the Middle East, to the United States for care. And that's a real issue for families for having daughters that have dislocated hips in terms of marriage opportunities. And then the other thing I think you have to think about when you're taking care of these patients, whether you're doing it in your home area or you're doing it abroad or you're doing mission work, is thinking about what the salvage options are down the road. Is there access to total hip replacements for this family and this area? And that can certainly affect your decision making early on. So that's dislocations. So we go to the middle of that three-panel screen that I showed you early. So subluxations have the worst natural history. And this is a little bit counterintuitive. I think a lot of my early residents think a dislocated hip is the worst and a shallow hip is the best. Well, actually, the worst is a subluxated hip. If a hip is partially in and partially out, you essentially get edge loading, and those hips have the absolute worst natural history. It's much better to have your femoral head up in the ilium, sitting in the abductors, not articulating with anything from a pain standpoint than it is to be sublux. So as I said, you get a lot of edge loading, a lot of instability. These joints have the most rapid degeneration. These are the kids that can be symptomatic even at the age of 7 or 8 with a subluxed hip causing degenerative changes. And so these kids have the highest risk of pain, which is typically true groin pain or abductor fatigue. There's nice long-term data going way back on the natural history of subluxation, going all the way back to Weiberg's work. We know that subluxation is a very poor predictor for the health of the hip joint, and this has been shown in several classic studies. And this X-ray shows a rim fracture from a subluxation that has caused degeneration of the joint. So that's subluxation. And then the last form of those three forms is stable dysplasia. So hip-centered acetabulum just insufficiently formed. Now, this is really interesting to me because I take care of babies and I take care of young adults, is to think, like, is it really the same disease? Is it the disease that we're just not catching it when they're infants and they grow up later and they have it? Or are some of these kids look totally normal early in life and then just don't fully ossify or mature their pelvis later? And I think the answer is it could be both. But we tend to think of it as like we think of our babies who have DDH and then our teenagers that have DDH. But clearly there's some link between the two, but I do not think it's one-to-one. And there is some studies out there showing that if you look at the demographic differences between teenagers that show up with shallow hip sockets and babies that are treated for shallow hip sockets, there is some difference in terms of family history, prevalence, bilaterality, breach histories. But at the end of the day, mechanically, the hip behaves the same, okay? So if it is shallow, it is dysplastic, you have the same mechanical problems. And the mechanical problems are that pressure hurts, okay? So essentially, when you have a shallow hip socket, you have a smaller cartilage contact area in a static model, and that increases your contact pressures. And this is one of the areas in orthopedics where biomechanical models mimic the clinical situation quite closely. And it's a very nice model of how arthritis develops. So increased pressure, smaller surface area, increased stresses, more load on the cartilage, earlier breakdown. And again, lots of classic long-term studies looking at what that means clinically. So Dan Cooperman and Steve Murphy basically showing that if patients have shallow hip sockets, the risk of getting osteoarthritis is very, very high. And this has been shown over and over and over again. And I would say one of the areas where we have pretty good natural history in the area of pediatric orthopedics. So if I were to summarize the relationship between hip dysplasia, arthritis, and then, of course, the eventual need for a total hip replacement, this is what I would tell you. It's essentially the leading cause of early onset osteoarthritis in patients under the age of 60. It's the leading cause of osteoarthritis causing total hips, or it is the cause of osteoarthritis requiring total hips in about 48% of patients under the age of 50. It's the most common overall cause of hip arthritis in women, and depending on some old measurements, it might be responsible for about 10% of all total hip replacements. So that's a lot as far as the burden of care. So this is very old data. I'll show you some updated stuff, but the bone and joint decade was a time that ended in 2010s where the U.S. put a lot of time and energy into figuring out the burden of various diseases. And so this ends in 2011, which is obviously quite outdated. But at that time, it was about 306,000 hip replacements done in the United States in terms of that. These are more updated numbers looking at kind of where we are as we head toward 2030. And you can see the numbers have skyrocketed. So over 800,000 total hip replacements are projected to be done in the United States by 2030. And you can see by 2040, it's going up to 1.4 million is the projection. So these are a lot of surgeries, right? And then, of course, what comes with that is cost. So using these projections that I just told you, we project about, and this is just hospital charges, okay, which is just one part of the cost, right? It doesn't count indirect costs of lost work or lost productivity, so on. But hospital charges, by 2030, we're talking about $48 billion in total hip replacement costs, 2040, $81 billion. So you don't have to be a mathematician to figure out what 10% is. So you think about 10% is from hip dysplasia, that's $4.8 billion a year in 2030 and maybe $8.1 billion a year in 2040. So lots and lots and lots of money. And again, these are just hospital charges. It does not include, again, indirect costs on the family, lost productivity at work, and so on. So why is hip dysplasia important? Well, I would argue it's a really significant source of musculoskeletal disability and osteoarthritis, which has issues later in life. It's a tremendous cost to society in terms of productivity and just the straight-up delivery of medical care. And I would argue that if you can identify it early, it's preventable or at least treatable early. And so perhaps an area that we could do better. So just to kind of summarize this, we'll talk about ultrasounds a little bit more later today, but this is a hip that is, sublux, partially out of place, has a shallow socket. We can apply a pretty straightforward device made of Velcro and webbing. And we can have a happy baby with a happy hip after a few months. If we don't do that, later on, we can have a patient who has a shallow hip socket, gets a total hip replacement, and can be very happy as an adult. But again, when you think about the cost of society and the morbidity and the lost time, there certainly are some factors to consider there. From a cost standpoint, again, this is also a little bit older data, but the implant, just the cost alone of the implant, about $5,000 to $10,000, depending on where it is in the U.S. money. And then if you go on Amazon, you can buy a Pavlik harness for $65. So obviously a little bit more cost effective as we think in the United States about cost containment. And you guys have similar issues everywhere as well. All right. So the next thing I'm going to talk about for a little bit is who should be screened. And again, for the pediatricians that I interact with at my institution, this is what they're most interested in is, what's the up-to-date, who should be screened, when should we be screening it? And so I'll spend a little bit of time talking about that. Hopefully you'll find that useful. So when we think about screening for anything, okay, these are the factors that you have to think about. So how important, how big is the disease? How common is the disease, right? So if you have a very, very rare disease in your patient population, it doesn't make sense to create screening infrastructure. The higher the prevalence of disease, the much larger the ROI on creating a program to screen for it. You have to have accurate tests, right? So you want to have good sensitivity, but also good specificity. You have to have intervention that makes sense, right? So if you screen for something and there's nothing you can do about it, that's not super helpful. But if there's something you can intervene and actually make a difference in the natural history, then that makes sense. And then cost, right? These are all, if you're going to institute this society-wide, then it has to be relatively cost-effective. So if you look across the world in terms of how people screen for hip dysplasia, you'll see that a lot of Eastern European countries, where again, there's a much higher prevalence of disease, for those governments, they've sorted out that it makes sense for them to have universal screening. And when I say universal screening, I mean universal ultrasound screening, okay? So all these babies in these countries get ultrasounds. Depends a little bit on the age, depending on the country, but that's what they do, okay, to screen. Then the other part of the world, or most of the world, does selective ultrasound screening. So they will call it universal screening because every baby gets examined for hip dysplasia. So they will call it universal screening, but we're talking about universal ultrasound screening. So in Canada and the United States, these governments have chosen selective screening, meaning that if the patient has an abnormal physical exam or a risk factor, then they get sent off for an ultrasound, but it is not routine to have everybody sent for an ultrasound. So in the United States, the Preventive Task Force, along with the American Academy of Pediatrics, advocates that all infants who are born get a clinical exam looking for hip dysplasia. So if any of you have your own children or have been in the newborn nursery or in your pediatric rotations, you know that, in the newborn nursery, the pediatrician will round, they'll feel the hips as soon as the kids are born, and then they're supposed to feel the hips at every single well child check after that, okay? There's this concept of surveillance versus screening, which at least is in the American guidelines, which never made a ton of sense to me. But this is what the pediatricians are taught, at least in our country, which is that if the exam is equivocal, to just bring them back and repeat the exam, which doesn't make a ton of sense to me because, as we'll talk about a little bit later, the exams can get a little bit more difficult as time goes on in hip dysplasia. But that's that idea of surveilling. And then screening would obviously be sending that patient off. And as I mentioned several times already, there's no universal ultrasound in the United States, and ultrasound should be prescribed selectively for risk factors or an abnormal exam. In Canada, similar kind of thing. So serial clinical exams on infants. Your Preventive Task Force is not advocated for routine radiographs or routine ultrasounds, and same thing, selective ultrasound for risk factors. So what are those risk factors, okay? So the first one is obviously physical exam, okay? And you guys are all taught this, I'm sure, in your first few weeks of being on a pediatric orthopedic rotation, which is to examine the hip, feel the baby's hip, and what you're feeling for as you perform the classic Barlow and the Ortolani maneuvers, are you feeling this hip kind of clunk either in or out? And I tell trainees that it's a sensation of kind of something coming over a speed bump. It's kind of a deeper thud. It's not like a high-pitched click like cracking your knuckles. That's often what gets identified as a click, but that's not quite what the feeling is. And this whole idea of clunk versus click is an issue about the way Ortolani's treatise was translated from Italian over to English. He really intended it to be a clunk, but it got translated over as a click, and that has caused some confusion. The Barlow test, you have to know, is basic pediatric orthopedics, is a test of dislocatability. So the hip is sitting in the joint at rest, and on that top picture that Netter drew, if you put a little bit of posteriorly directed force, if you feel it slide over that speed bump and feel like it's coming out, that's a positive test. If the hip is being treated, you don't want to keep pushing on it because you can keep pushing the hip out. You just want to do it kind of once. That's a diagnostic test, and then kind of move on from there. I will tell you that you got to be gentle. I teach my trainees this. If you push really, really hard on any infant, you will push their hip out. And I tell people if I see them squeeze and the blood pours out of their capillary beds because they're squeezing the leg so hard, A, the kid will contract, you'll get a bad exam, and B, you can overpower a 6-week-old. So this is a very gentle exam, and I think that's one thing I would pass along to pediatricians, that it's often done too vigorously, and I think it's less reliable. The Ortolani test is a test of reducibility, so the hip, by definition, would be sitting dislocated at rest. You abduct the leg, put a little bit of upward force on the greater trochanter, like you'd see in that bottom picture here, and you're lifting the greater trochanter up over the posterior rim of the acetabulum to see if it goes in. If it is, it's reducible. Remember that you can have a negative Ortolani test in a irreducible hip. So just because the Ortolani sign is negative doesn't mean the hip is located. It just means it's not reducible. Okay. The other thing to keep in mind, and this is why I bristle a little bit at the surveillance concept, is that these tests are only really positive in the first few months of life. Occasionally, you'll get a 5 or 6 month old that still has an Orlani positive sign, but generally, soft tissues start to tighten up as the hip stays dislocated over several weeks, and the hip is just not as loose, and you don't feel that same popping in and out that you do at 6 weeks. You may not feel that at 3 or 4 months without any change in the hip position. And so, again, that's why that idea of surveillance is going to push you in a wrong direction, because most likely the exam will get better, but that doesn't mean that it's normal. All right, so what are some other clues you could use? So the Galeazzi sign, which of course is looking at the lengths of the femur. So if you assume that the femur is the same length, which is not always true in the world of pediatric orthopedics, but if you assume the femurs are the same lengths and you level the pelvis, if the knee height is off, it implies that that femoral head may be more proximal and therefore dislocated. Abduction is very, very useful, especially in older patients. So, this is where you have to have your hands on a lot of hips to get a sense of what normal is. But if one side is significantly less than the other, that's a clear tip-off. The problem in this is if you have bilateral dislocations, you can have bilateral reduced abduction, and that's harder for your brain to pick up. But you really should be able to abduct 60, 70 degrees in a kid. And if it's 30 or 40 degrees that it comes out, that's pretty abnormal, and I would think about that. And then asymmetric thigh folds, I'm sure here, like they are in my institution, is a reason for a lot of referrals. That's really unreliable in terms of that being a source of true hip dysplasia. All right, let's talk about the hip click. So the isolated hip click, very common reason for referral to a pediatric orthopedist. So this is not patients who had breech or any other family history or any other risk factors. So just kids that had an isolated hip click. This is a study out of Texas Scottish Rite. And they looked prospectively at 255 infants who had an isolated click, and this is what they found. They found that 3/4 of them were totally normal, but they found some DDH. Okay, they found 20% hips were slightly shallow, 5% were severe DDH, and so they recommended in this study that all hip clicks get sent over. Okay, now I would argue, and this is going to be a theme through this talk at all, is when you do this screening, it depends on what you're looking for. If you are screening for dislocated hips, then the hip click is probably not that reliable. However, if you're screening for any form of hip dysplasia, the point is that there's a lot of hip dysplasia out there that doesn't get caught unless you screen it with an ultrasound. So that's why you look at all these studies, you will, if you image 150 kids with ultrasounds, you're going to find hip dysplasia because I told you it's out there at 3 to 5%. And so do I think the hip click necessarily always means that the hip is unstable? No, but I think that may indicate that there's some abnormality and that you may catch the more milder forms of hip dysplasia, which I think is still worthwhile. So one of my concerns about the selective ultrasound policy that both Canada and the United States use to define whether or not to get an ultrasound is that physical exams are limited. Okay, so this is a study I was a part of. We looked at 515 dislocations that we knew on ultrasound were dislocated. Okay, so no doubt they were 100%, they were dislocated on ultrasound. And then we looked back at what the expert pediatric orthopedic, not even pediatric orthopedic hip expert, what they felt on their clinical exam, blinded to the ultrasound. And about 14% of dislocations were missed. Okay, and so this paper that we published a few years ago has been picked up by a lot of lawyers in the United States, and I get lots of calls about defending pediatricians because this paper has my name on it, and I say the same thing, which is that it's not always easy to feel an Orlani sign. Kids crying, they tighten up their muscles, they're cold, the hip just doesn't relax at that moment. It's just not 100% reliable. And so again, 14% of dislocations were missed clinically. This also, remember that not all dislocations are Orlani positive, right? So irreducible dislocations, you're not going to feel. So the point here is that that physical exam screening tool is flawed. It's not perfect. If you accept it for what it is, fine, but you can't assume that physical exams are going to catch every single dislocation. So, and then further on in the study, we found that 20% of the dislocations actually had full abduction. And then when we were judging whether hip was reducible or not on our exam, we were off 10% of the time. So we talked about physical exam. Let's talk about other risk factors that would indicate screening, potentially with an ultrasound. So breech, very classic one and a real one, okay? So there's a 6 to 10 times increased risk of having hip dysplasia in a breech position versus cephalic presentation, okay? The overall prevalence in breech kids is higher, 2 to 15%. Frank breech is the highest. And theoretically, the more time spent breech in the third trimester increases your risk. The problem is, and I get asked by families this all the time, like, you know, they had a couple ultrasounds and they were breech for a week and then they flipped back. You know, is that breech? I don't know. We don't have any kind of study to say, you know, this many weeks is breech and this many weeks is not breech. You know, we assume it's a cumulative exposure. The longer that you're breached, the longer the stress is on the hip, which could then theoretically increase your risk of DDH when the patient is born. But none of us really know. We don't have the serial ultrasound data to answer that question. So we tend, as orthopedists, we try to make things simple. So we just say you're breech or not. And if you're breech, even if you're a 1-day breech or a 3 months breech, I'm going to treat you the same. But families often ask that, and I don't have great answers for that. I think one thing that's a little bit of an evolving standard in our area is, what do you do after a first ultrasound? So I think it's pretty well understood in the United States, and I'm sure here as well, that breech kids should get an ultrasound. So what happens if you get that ultrasound and it's normal? Are you done? Okay. Well, there's a study out of San Diego, and we have a study as well from several years ago that showed that even after a normal ultrasound in a breech kid, we found 10%, they found 30% risk of radiographic dysplasia, not dislocations, but of the milder form of the disease at the 6-month x-ray. Okay, so we have changed, since I've been in practice and we published this study, we have changed our local area to have patients follow up at 6 months of age with an x-ray, even after a normal ultrasound. Now, to be clear, this is not a recommendation in the American Academy of Pediatrics. This usually creates a lot of consternation among my pediatric partners, because it's like, where's that written? And I'm just like, well, you know, this is what we publish, this is what I recommend, but it's certainly not, I would say, a national expectation. But I do think that there is a sizable number of patients who have radiographic dysplasia that could theoretically be treated with part-time bracing. All right, so that's breech. Okay, family history, next major risk factor, very, very clear. We know from other work that's been done that hip dysplasia is, you know, it's multifactorial, but certainly there are genetic elements to it for sure. There's a 12 times increased risk in first-degree relatives. Parents, you can see, certainly have a higher risk of having a child, and then the more children and the more people in the family, the higher the risk. So family history is a very, very strong risk factor. The problem is that it's sometimes hard to elicit. A lot of people may not remember what they were treated like when they were a kid. Their parents might not be with them to remember. And so I think you have to ask a little bit more of, do you have hip dysplasia? So I'll ask, you know, was anybody in a bracer or harness when they were younger? Or did anybody have surgery? Or did anybody have a hip replacement, you know, prior to the age of 50 or 60? And they'll be like, oh yeah, you know, my aunt had a hip replacement when she was 35. Playing the odds, that's probably hip dysplasia. All right. Let's talk about swaddling. So this is something I think that's been a little bit more on people's mind over the last decade, okay? So infants, when they're born, have a natural hip flexion contracture, right? So they're a little bit flexed, they're a little bit externally rotated, okay? And they actually don't typically lie perfectly straight. Now, if you take those hips and force them into extension, what you're actually doing, if you go from that top picture to the bottom picture, you're actually creating a force that tends to drive the hip more lateral out of the joint, okay? And there is some data, both in Native American population and in some animal models, which I'll show you, that if you force legs into extension at the hips, you can have a higher rate of DDH. And so, looking at this from a different side, in Japan, when they changed their swaddling practices across the country, the rate of hip dysplasia went from 1 to 3% down to 0.2% just by changing swaddling practices. So that was real. There are some animal models to support this. So there's a nice study that was published maybe 10 years ago in JBJS where they basically bound rats, their legs and their tails in full extension right away when they were born, for 5 days and then for 10 days. So they had various different groups. And what they showed is the patients that were swaddled in extension like this right away, for 10 days, 82% of those hips became dysplastic. For 5 days, they still had dysplasia. So all of the groups who were bound in this way certainly developed abnormal hips. And you can see this is a picture of a Ecuadorian kid, and it's the exact same thing as that rat. So that's what we're trying to avoid with education. In terms of the AAOS, the American Academy of Orthopedic Surgeons, so the guidelines for screening, and this was most recently updated in 2022. Again, we've talked about this, basically that there's evidence to support before 6 months of age, if you have breech history, family history, or an abnormal physical exam, to go ahead and get an imaging study. When you dig a little deeper into this, where this comes from is primarily 2 large randomized controlled trials from Norway talking about how selective ultrasound with high-quality clinical screening, which I told you is a question, is the most cost-effective way to go. And that primarily universal ultrasound is not recommended both in Canada and the United States, not because it couldn't be helpful, but because essentially the cost doesn't justify the outcome. They don't think the expense and the high false positive rate is worth what you get. So what do you get? And so this is the data behind those 2 RCTs that has driven really a lot of the screening recommendations both in the United States and Canada. So this was 1994, 12,000 patients in an RCT, universal ultrasound and physical exam versus selective ultrasound based just on physical exam, and then a third with physical exam only. And they eventually found a lower rate of the late diagnosis in the universal ultrasound, but it was not statistically significant. So yes, there were more dislocations, but it was very few, and it wasn't enough to reach significance. And the question is, again, does that justify the cost of what it takes? So, the real question then is, if it was a pretty big sample size, but could you go larger? Would you find significance? How many dislocations are acceptable as a society to say that's okay? These are unanswered questions. Another RCT, 15,000 infants. Only 1 late dislocation in the universal ultrasound that was caught, 5 in the selective ultrasound, or were missed, and 5 in the selective ultrasound group. So again, 5 versus 1 in 15,000 infants. Not a lot if you think about it from a public health standpoint. And so, again, this was a study to support the fact that universal ultrasound was not necessarily worth it because they weren't catching all these dislocations. My criticism of this is you're looking just at dislocations. If you consider other forms of hip dysplasia, then the calculus changes. So on the other side of that argument, so those were 2 studies supporting what is being done, which is selective ultrasound, saying that there are not that many out there that you're missing. There's another side to the argument as well. So this is a study from my friend Leah Donnan in Australia, which was a retrospective review of patients that came into their infant hip dysplasia clinic. So 192 infants that came into their clinic, and they found that 100 of these had hip dysplasia that was not picked up by exam and selective screening. So again, that's because they're including things like moderate dysplasia, not just dislocations. So there's also several other studies showing that universal screening does decrease late detection. Again, depends on how you define hip dysplasia. Universal screening with ultrasound does reduce surgery rates, but the problem is that the costs are higher. And so it reduces your operative costs because you don't have to take patients to surgery, but obviously the screening costs are higher because of the number of patients that have to come in to get studies done and then have those interpreted and then potentially get follow-up. So the biggest issue, I think, in this universal ultrasound struggle is that there's a significant cost of overtreatment. This is what always gets cited because of the appointments that get created, the follow-up ultrasounds and stuff, and that cost, most people believe, at least from the administrative level, that does not justify the means. So one of the things to think about is how could we reduce those costs, right? How could we make universal ultrasound cheaper overall? And there's a couple ways to do it. So if we reduce the false positives, then we can make a better screening test, and that would potentially drive down the overall cost. And so this is work that's being done at the University of Alberta with Jacob Jaremko, using a lot of 3D ultrasound, and he's used it for screening, and it's basically showing that if you use 3D ultrasound technology, which is kind of one step up from the two-dimensional stuff that we're used to, you can cut down on the number of immature hips that would get better on their own. And so they've shown lower variability between scans and more predictive value for patients that were actually having hip dysplasia that need to be treated. So potentially you could cut out a bunch of people that we bring back unnecessarily. Then we talked about this last night. There's also options for cheaper ultrasound. So ultrasound, as you know, is becoming widely available. This company has a option that you can plug into your iPhone or an iPad. It can be used everywhere, and potentially this could be an extension of a physical exam. And especially if you're screening for dislocations, there may come a day, if pediatricians become comfortable with this, where you could, like a stethoscope, just put this on the hip in your office. You might not catch every dysplastic hip, but you can certainly catch dislocations. And these are relatively cheap and will become cheaper as time goes on. All right, so that's about screening. I'm now going to move briefly into talking about kind of diagnosis and management. So as we've talked about, the diagnosis of hip dysplasia really rests on two things, which is a good physical exam. We talked about the flaws with that. Ultrasound, which is the best imaging test under 6 months of age. And then x-rays, where we typically switch around 6 months of age to getting x-rays. So real basics on an ultrasound for people that are maybe less interested in this. So the alpha angle is one of the numbers we look at, and it's this angle here, which is the angle between the oblique line along the acetabular surface, which is this bone here, and then the side of the ilium, which is this here. That creates an angle. The bigger the angle, then what means is that this angle, which is the same as this, becomes more vertical, and that means that that femoral head is more covered. So a bigger angle is less dysplasia, a smaller angle is more dysplasia, and we generally want the number to be over 60 degrees. Percent coverage is even easier. In this, what we're doing is we're drawing a line down the ilium, figuring out how much of the femoral head it cuts. We're looking at what percent of that, so X over Y, what percent of the femoral head diameter is underneath that line, and we like that to be over 50%. At 6 months, like I said, we switch to x-rays, generally because there's more ossification in the proximal femur, although not always in DDH. It's sometimes a little bit delayed. The biggest thing that x-rays allow you to do, well, first, you can grossly figure out the position of the hip. This was mentioned in Journal Club yesterday. This is the International Hip Dysplasia Institute classification, and this is a grade 1, which is a normal hip, which is the center of the metaphysis is on the lower inner quadrant, and then as it goes farther out, it goes from a grade 2 to a grade 3, and then if it's a high dislocation, it's a grade 4. I think radiographs are most useful to quantify acetabular dysplasia, similar to how that alpha angle is drawn. So we draw the acetabular or Hilgenreiner's line, which is this horizontal line. We draw an oblique line along the sourceal. That creates this angle, which is the acetabular index, and that's essentially the radiographic analog of the alpha angle. So it quantifies how shallow or not shallow the hip is. So when we look at an x-ray like this, the first thing we think about is the position of the hip. So there's the femoral head. It obviously should be down here, okay? So we can understand that that hip is dislocated. But if you look at the other side, I would say that hip is not fully centered either. So I'd be worried about that being a subluxated hip. And so we can figure out that from x-ray. Then the other thing we can look at, again, are the obliquity of the weight-bearing surfaces of the joint, the radiographic weight-bearing surfaces, and that gives us a quantification for how shallow those hips are. So that's dysplasia associated with dislocation on the right side and subluxation on the left. Basic treatment principles in hip dysplasia: the earlier we get to these hips, the better. No doubt about it. If you can get a hip in at 6 or 8 weeks of age with a harness, you will have essentially a normal hip if they respond well. If you get a hip in at age 2 with surgery, it will never be a normal hip. It'll be significantly better, it'll be functionally better, but it will not last them forever. So we definitely want to get to these hips earlier if at all possible. The more severe the disease, the more highly dislocated, the more abnormal the pelvis, the more we have to increase our level of intervention in terms of doing bone work. And then I would also say follow-up is absolutely critical in this disease. We talked about this last night. You can have really nice results for 1 or 2 years, and then things can change over time. That's the great unknown of growth. And so we follow these kids all the way through maturity. So real briefly, for patients who have stable dysplasia, so just alpha angles that are abnormal, a little bit low femoral head coverage, but they're not subluxed or dislocated, we tend to observe these in the U.S. until they're 6 to 8 weeks old, because some of them will get better on their own. I think there's definitely controversy. We talked about this last night for patients between 8 to 12 weeks, and there's an RCT that you guys are a part of, that we're a part of as well, trying to answer this. But I think some people will observe these hips, some people will treat these hips. By 3 months, I think most people will treat hips that are still dysplastic. This is where I think there's that big overtreatment cost, because again, a lot of these hips will get better. And so this is the kind of area I think if we could improve, we could actually improve the cost effectiveness of universal screening. So if I do treat, how do I treat? I do use the pelvic harness a lot, but I actually use 4 braces in my practice. I do switch around a lot, but this is my standard brace to start. For just dysplasia, not a dislocation, I start at 23 hours a day. I let them put it on over a layer of clothing. I let them take it off for changes in baths. That's a stylistic thing. I don't think there's 100% standardization across the world about this. Typically, stable dysplasia will get better in about 6 to 8 weeks, 90% success rate. If there's any residual dysplasia, then I'll do some part-time bracing after that. And then, as I said, really important to follow these kids up. I tell families that once we start treatment for hip dysplasia, it's like getting weight checks when they go to the pediatrician. They have to hit their marks at every time to make sure that they're still on their hip curve. And so I tell, again, the same analogy. I say, if you're the same weight at 6 months as you are at a year, as you are at 18 months, what was normal at 6 months is no longer normal at 18 months, and you're actually losing ground. So similarly, the hips are supposed to deepen as you grow up. And so I want to see these metrics improve on this normative graph over time. And we plot that out in the clinic, and we keep it in our notes to figure out which way they're going. So that's stable dysplasia. That's subluxation or dislocations. I treat those at any age. It's not an emergency. They don't have to come in and start at the day 1 of life. But I do, I don't arbitrarily wait till 6 to 8 weeks of age to treat these kids. I don't love treating kids in the NICU or the nursery. It's just, there's a lot going on. There's lines, there's other priorities. I find these kids are swaddled on top of the pelvic harness, which kind of defeats the whole purpose. So if I have my preference, I like the kids to get discharged from the NICU and then start treatment. You can't always do that, but that's my preference. And then for kids that are subluxated or dislocated, I use the harness 24 hours a day. I do that for a couple weeks, repeat an ultrasound in the harness if the hip is stabilized and I gently feel it. And if it hasn't, if it's still stable, that's when I'll drop down to 23 hours a day. And then typically these need a little bit of longer treatment for that SM to fully normalize because it's more severe hip. And just like the stable dysplasia, we follow them. In terms of outcomes, lots and lots of studies on pelvic harnesses. This was, I think, a study we're proud of from the International Hip Dysplasia Institute. It was our first major study that we published several years back. This was a prospective multi-center study looking at 162 Ortolani-positive hips. We found a 79% success rate with the pelvic harness and better results if we started the treatment by 7 weeks of age. So not everybody will respond, but the majority of hips will respond. Complications of the pelvic. So this is a pretty safe device. It's just a hunk of Velcro, and it works pretty well. There are issues to be aware of, but they are fortunately rare. So this is for all sorts of in-service or board questions that come up. So femoral nerve palsy is a risk of pelvic harnesses, especially if you excessively flex the harness. Bigger kids are a risk. Dislocated hips are a risk. So fully dislocated hips. Excessive abduction in the harness, perhaps over 75 degrees, can increase your risk of osteonecrosis. And then if you leave a hip dislocated for weeks and weeks and weeks in a harness, you could theoretically cause changes to the posterior wall, which can make subsequent reduction surgically more challenging. So that's called pelvic harness disease. So the dogma is to abandon the harness if it has not improved in 3 to 4 weeks. I don't fully subscribe to this, but I think that's what you should answer for your testing. Rigid bracing, another great option that I think has undergone a little bit of a resurgence. As I said, there are lots of braces around the world for hip dysplasia. If you travel, you'll see, the pelvic is just one device that's typically used in North America, but there are tons of devices out there, and all of them have success rates. So rigid bracing is a totally different philosophy. You're kind of setting the abduction in a certain position. You're not using kind of gravity and motion to guide the hip in. It's hard to do on a really, really small infant because their thighs have to be big enough to get a cuff on. But I think it's a really useful plan B. I like to use it for older infants, larger infants, and patients that have failed a pelvic. We wrote this study in JBJS many years ago, looking at a cohort of patients that had failed a pelvic harness. We found that 80% of them were able to be stabilized with an Ilfeld brace, and we did not have any cases of osteonecrosis. So this was a case from that paper. It was 4 weeks in a pelvic. You can see the femoral head is still up above that ilium, so not reduced. 2 weeks in the rigid brace, it starts to drop in, and then it starts to improve at the end. So a nice result for that kid. Closed reduction in spica casting, that's kind of the next step up if patients fail pelvic and then rigid bracing. We usually do this with an arthrogram to check that the femoral head is fully seated within the acetabulum. Depending on where you are in the world, some people do tenotomies to loosen the hip up. If it's a little tight, preoperative traction. This is Goldilocks surgery, right? You got to get the hip not too tight, not too loose. And this is really, I think, the art of DDH surgery is what's good enough. how stable is stable, how good, how much are you pulling to put the hip in? That's the stuff that's hard to teach in a lecture, but that's where you just got to get your hands on these hips and really stare at arthrograms. I'm an arthrogram geek. I love looking at arthrograms. I think they're super neat, and just seeing how the cartilage is and the labrum and the limbus is really neat. Spica cast, by far the biggest challenge to parents. Hygiene, transport, it's a total headache, and so we try to really educate families to deal with it, but it's not easy. And then open reduction, of course, is there if you have blocks to reduction, intra-articular, really severe contractures. It can be done medial, anterior. That's a different discussion for a different day. And then depending on the age of the patient and the pathology, we often combine this with bony work, either on the pelvis or the femur, to alter femoral version, to shorten the femur to make the tension right, or to deepen the socket if the acetabulum is really dysplastic. So that's what that can look like. That's a femoral shortening with a Salter. Surgical complications certainly are there. I tell patients the redislocation rate, kind of all comers, is about 5%. Residual dysplasia, we talked about this last night, probably about 50%, depending on whether you do something additional. Risk of growth disturbance, maybe not clinically significant, 40%, but I think 5 to 10% is clinically significant. And then stiffness, I think, is something that people haven't talked a lot about. We published a paper on this about a year ago, but I think about a third of patients have some stiffness after open reductions that can take a few months to kind of work through with physical therapy. And certainly it's better to advise those parents ahead of time rather than to watch their kid limp and have them be frustrated. So, all right, so take-home points. Hip dysplasia is really a wide spectrum of disease, from mild shallowness all the way to dislocations. It's super common if you think about it, compared to some of the numbers I showed you in some other pediatric diseases. Screening is controversial. I think there is room for improvement. I think on the provider side, we have to figure out ways that ultrasound can be cheaper and more accurate, and that might make it easier to be adopted. Bracing is usually successful. 70, 80, 90% of the time, if you can catch it early. And then if it's later or if they fail bracing, obviously surgery has a good place in the treatment. Thanks. So happy to take any questions. I guess I'm still on camera here.
Question?
Yep.
I'm very surprised by the Eastern European statistics. And do you have any thoughts on why that happens in that population?
Don't. We just know that we know that genetics plays a role for sure, and it's not surprising if you look back at the old literature, like Graf from Austria, Pavlik is from Poland. Like that. All that work is done in that area because that's where the prevalence of disease was super high. So I do not know specifically why that patient population, but clearly, like there's genes in that part of the world that have obviously spread as the world has become more global, but something about that disease, why do African Americans get sickle cell? I just think it's what happens in that patient population.
I've ordered you an X-ray, so you can just go and get one for screening. Any other questions? Any online questions from the audience? Again, thank you, Dr. Sankar. I think it's very important to be able to put this information out there. I mean, DDH is very prevalent, and I think selectively screening. But there's a question online, so.
Oh, thank you very much. Sorry, I can't work my camera, but I'm Michael, and I was wondering, often fetuses are breech into latent pregnancy, like 38, 39 weeks, and then babies are born vertex. So I was wondering, is there a gestational age when we should worry more about the risk of DDH with breech positioning in utero? Or is it just more how the baby comes out that's important?
So I don't have the exact answer. I would, from understanding the mechanics of it, I don't think it is the actual delivery. I think it is the amount of time spent in the breech position. So, and then I think it is also the amount of time spent in the breech position when the child is bigger. So I think if I had to quantify it, I would say the number of weeks spent breech in the third trimester, regardless of delivery, is probably the biggest factor. But as I said, we don't have a serial ultrasound study showing like, okay, there's a threshold. If you're breech for 2 weeks, yes, your risk goes up. And if you're breech for 2 weeks or less, you don't have a risk. So like I said, we tend, because ultrasound is relatively easy, tend to just send everybody for ultrasound.
Oh, thank you very much.
So-
And that actually raises another question. So if a baby is premature, often their breech, and often they're born by C-section. So if they're like 33 weeks or something, do we say, well, it's only 33 weeks, I wouldn't worry about it so much? Or is it, oh, they're born breech and just do the
Yeah.
ultrasound?
So there actually is data on this. So it turns out you do not have to correct for prematurity. So prematurity is neither protective nor a risk. You should actually, when you think of like I'm going to get an ultrasound at 6 weeks, you should just do it based on gestational age. So some people will wait and say like, oh, I have a 32-weeker, 6 weeks is when I'm supposed to get it, but they're 8 weeks premature, so I'm going to wait till 3 months. I would say no, do it on gestational age.
Thank you very much.
Yep.
There's another online question.
Hi, Dr. Shankar. Thank you so much for an excellent presentation. I have also two questions. I'm a pediatrician who does mother-baby units, so I see newborns often. Sometimes we get these twin deliveries where one is breech and one is transverse or, vertex. And so in those scenarios, is it worthwhile, doing an ultrasound on the twin that is not breech? Or what's your view on like transverse positioning?
That's a good question. I generally recommend getting an ultrasound on both. And again, it's because you can obviously tell my bias, which is that, more routine ultrasound would catch more disease. And so to me, if there's any question, I would get an ultrasound because it's just, there's no risk to the patient. It's a very simple study. And so, yeah, I usually recommend the twins there. There's obviously some increased risk with twins, and you don't know yet if one has it and the family history kind of issue and the genetics. So I usually have both twins, and I have several patients in my practice who are twins that both patients have hip dysplasia.
And sorry, one other question is on my other kind of role, I see a lot of neurodiverse patients, patients with autism, and they tend to be kind of lower tone, muscle tone. And so I heard you saying DDH later presentation. And I wondered in that patient population where they have kind of these lower tones, sometimes hyperextendable, joints, is it worthwhile also screening those patients so they'd be older and later? Or is it only just if exam kind of indicates that, then worthwhile?
Well, I think this is a little bit of a philosophical question. I think, and this comes up when I take care of, for example, like babies, but then they ask me about the older sibling who didn't flag.
Yeah.
So it's like a 5-year-old and I'm taking care of their baby sister.
Right.
And they're like, well, should I have my 5-year-old looked at? And the problem is in that is like, what's going to be your intervention, right? So under 2 years of age or under 18 months of age, I do some kind of bracing. Sometimes it's night in the younger toddlers. Obviously, in a 6-week-old or an 8-week-old, it's the Pavlik harnesses and the stuff we talked about. When I have a 4-year-old or a 5-year-old, there really are no interventions other than surgery. So in terms of like identifying it early, I tell families, I'm like, here's the deal. Like, what are you going to do with this information? Your kid's running around, has no symptoms. Am I going to operate on this patient? Probably not, right? So if you'd like to know, if you're the kind of family that would like to know and have that information, fine, we can get an x-ray. But truthfully, I'm probably not going to do much with that information at this time. So similarly, in your situation, when you have neurodiverse kids who have low muscle tone, as an aside, I would say like this whole idea of like hyperflexibility and low muscle tone, I do think there's a synergistic effect with slightly shallow hip sockets and so on. So these are all the body types that we tend to see are like in typical dysplasia are females who are really flexible. They're like the kids that go on to be dancers and gymnasts, right? And they have shallow hip sockets and they think they go together, right? The hyperflexibility is able to be done because the sockets are a little more shallow, or the opposite is, or the hyperflexibility creates the shallow hip sockets. Who knows? But this is like the kind of the type of patients we see. And I don't know, but I wonder whether those patients that are neuroatypical who have hyperflexibility maybe have a little bit more instability in their joint, and maybe the ones that have radiographic dysplasia when they're 9 or 10 or 11. But as I said, do I screen those patients? I don't after a certain age because I'm not really going to do anything. Now, obviously, if they have symptoms, that's a different story.
Perfect. Thank you so much.
Yep.
Any other questions? Okay, so there's a question on the chat about DDH in the premature population exchanging one lesson for
So I do not specifically know about a study. So the question is, sorry, I should read this question. So the question is to jump off the DDH in the premature population for extreme premature infants born less than 28 weeks. Is the best plan to screen to be sure we're not missing anything? Just to be super clear, up to date seems to suggest breach at 35 weeks gestational age is something more significant to consider for the risk of DDH in terms of my understanding. And this just makes me wonder about more premature infants and the data there is in terms of DH risk with prematurity. So I can't say that I can quote a study on highly premature kids like 28, 29, 30 versus 32, 33, 34. I just know that there's a couple studies that were pretty large that showed that that essentially you didn't need to adjust, that their hips should still be normal at 6 weeks of gestational age, regardless of that. Now, I don't know if we drill down, I don't know this data on the top of my head, if you drill down to the 28 weekers or the 29 weekers, whether those were a separate population, but my recollection is no. So as I said, I typically use gestational age as far as the timing to get an ultrasound. I still get it at 6 weeks of gestational age. And then in terms of the indications, same things we talked about: breach, family history, abnormal exam.
And one last question online about how ultrasounds are commonly used in ICUs and ERs. Do you envision that a general pediatrician or even a neonatologist could apply ultrasound, and how easy is it? I know that you do them in clinic, so you make some comments on that.
Yeah, no, I think, I think the next generation of people being trained in medical schools and residencies of all type, pediatrics, orthopedics, I think they're becoming more facile with ultrasounds. Like I don't remember when I started my practice, every anesthesia resident using an ultrasound in the OR to place IVs. But now that's, at least at our institution, it's what's done. And now there's ultrasound in the trauma bay to scan the belly for blood. And there's, that's used in the ED. And so I think it's becoming integrated with our normal delivery of care. And it is not that hard. It is really, really quite simple. It might be hard to get like these really nice measurements on the hip sockets. It's really easy to just find the femoral head and to figure out whether it's in the socket. Very, very easy to do. Musculoskeletal care, at least in the United States, is like a black box for primary care doctors. They do very little training. And so this is, I think, another hurdle to have some comfort with even DDH exams is one thing, and then the next step is obviously an ultrasound. But I do think at some point there will be enough ultrasound in everyday training in medical schools and in all types of residency that people will start to be able to do this. It really isn't that complicated.
All right. Well, thank you, everybody. Thank you for your attention. And, with the residents, we'll have a wonderful day talking more about pediatric hip conditions. So, Dr. Sankar, thank you for your talk.
Yeah, thanks, Sarah.